So one of the most difficult cases of my career. So I had an interesting time putting this together, and what I did is find 4 cases out of a myriad of very complex surgeries that I've done in the last 30 years that kind of highlight, I think, important points that I've learned in my career. Maybe approach that from that perspective. So hopefully that'll be educational to people and lead to some further discussion. So I'll just jump right in. I think the cases will be pretty self-explanatory when you see them. The first is this 10-year-old with the severe congenital Lordos Scoliosis. And she presented to me at the Shriners Hospital. It was back in St. Louis. Again, she's 10 years old. And she presented not only for her deformity and disfigurement, but really for a brachial plexopathy from this iliac axillary deformity. So her right arm would go numb on her. I've never had a patient with such a severe deformity in the coronal plane, at least. In addition, and this is true, she had these 6 MRI abnormalities on her total spine screening MRI. You can see there she had an Arnold Carey with obviously syrinx below, some cervical stenosis just from a small canal, diastole amelia, diplomated and tethered cord. So she had the Arnold Carey decompressed and the tethered cord released. And then we were ready to treat her deformity. So the question is, what is best for this girl with an obvious, very abnormal neural axis, as well as a very stiff and abnormal spinal column. So not surprisingly, what I learned a long time ago is that we put her in halo gravity traction. Thankfully, her mother was a nurse, very attentive. So after a few weeks at home in the Shriners Hospital, she was from Kansas City, we let her go home. One of the few patients I let go home and she ended up being in traction for 9 months. And here's the result in the coronal plane after 9 months of sustained traction. You see we got her axilla out of her iliac wing. And she did very well with this, obviously slow gradual traction with no neurologic abnormalities. That's what we've seen over the years using traction as a great corrective technique with slow and gradual correction. And then, obviously couldn't keep the halo on forever. So we did this modified growing rod placement, basically with kind of one of the initial kickstand techniques where we basically pushed her trunk off her pelvis with the kickstand device on the far right side there. And managed her reasonably well with this procedure for several years of growing rod lengthening, and then ultimately definitive fusion on her. So here's her pre and post-op photos following that. Obviously looking better, but not perfect. She's still forward in the sagittal plane, and that was when she was now a mature young adult. I think 17, 18 years old. This was one of her complaints is that her trunk muscles would tire early because of fatigue because of her trunk being still forward on her sacrum and pelvis. So to fix that, then in New York, I basically did a L5 PSO and kind of translated and pushed her sacrum and pelvis forward, anteverted that, and pulled her trunk posterior with correction maneuvers. And here's her final resting position after that in the coronal and sagittal planes, reasonable alignment. So here she is from where we started to where we finished. She grew, I think, about 16 inches and has done well with that now at age 18. So here's her final photos. So again, well, what did I learn from this case? The value of prolonged halo gravity traction for very complicated issues. It's really the safest way to correct severe deformity, especially associated with abnormal neural axis problems. This kind of growing rod kickstand distraction technique, which is well popularized now for many coronal plane abnormalities, is very helpful in her to keep, again, her trunk off her hemipelvis. This L5 PSO for putting lordotic trunk on a flex sacrum, as well as obviously the need and requirement of using plastic surgery help for their wound closures because their obviously muscles were very severely involved as well. So a reasonable result from a very difficult problem without any neurologic issues and nor wound issues along the way either in this young girl. Second pediatric case is a little different twist. This is a patient with monomeningocele and a fused lumbar hyperlordosis deformity. So here's this 8-year-old who had meningocele and a lumbar meningioma resection by the surgeon who simultaneously did a posterior instrumented fusion at age 8. So here she is already with lumbar hyperlordosis, which has made a little more lordotic with that procedure. Her meningocele was resected. She's got 74 degrees of lordosis, and she was followed by this surgeon and then referred to me at age 19 now with this very severe fixed hyperlordotic deformity. So she's got 122 degrees of lordosis, pelvic incidence of only 25 degrees, so she's got a nearly 100 degrees mismatch. You see severe lumbar lordotic contracture of her distal spine and her pelvis. And unfortunately, not only was she fused posteriorly, but she's got a rock solid fusion anteriorly. So think about that for a second. How are we going to correct this severe fixed deformity of hyperlordosis, where she's got a solid anterior column and a solid posterior column with posterior implants in place? I've done one of the last anterior procedures I did in my career actually was a hyperlordotic cerebral palsy patient, where we went anteriorly to release the disc in preparation for the posterior procedure. But releasing the disc anteriorly here still requires us to cut her in the back, because she's got an instrumented fusion in the back. So that's the only way to do that. And so here's her clinical presentation. You see the severe crease in her back with very poor skin, and I got a meningocele there, so she has no muscle there in the midline either. So a very challenging procedure from a wound issue perspective. Not surprisingly, we had our plastic surgeons involved early on. We put tissue expanders in her, and here she is now prone with maximum hip flexion on the OR table with her tissue expanders then basically released from their expansion, and see the huge gully that we have to expose through. And honestly, I wasn't sure if we could expose this, to tell you the truth. And this is one of the hardest exposures I've ever done of the spine in this condition. And here's a little kind of close-up view after tissue expanders were completely removed. But there's a deep lordotic crease here, basically right down to her neural elements, because she's had a laminectomy and she had a meningocele. She has no muscle there. So we had to do very, very careful dissection. I think the dissection took about 4 hours that I did with my fellow, just to expose her spine, get her skin and soft tissue off her neural elements. Amazingly, we did not have any dural tear doing that, amazingly. And we got her exposed. And here's her final position about, I think, 13 hours later when the plastic surgeons closed her. And when we did on her, actually, I didn't do an apical resection. I did a L5 resection because, honestly, the apex L2 was just too deep a hole, I felt. And so what I did is I disconnected the spine from the pelvis with an L5 resection. Then over the course of 5-6 hours, we slowly distracted initially her rib cage off her pelvis with temporary fixation, and ultimately her spine off her pelvis with the distraction device that you see that ended up being a permanent device, to slowly push her sacrum and flex her sacrum down to decrease her lordotic curvature. So amazingly, with a complete laminectomy from L1 to sacrum, also to let her entire dural sac egress dorsally, she had no neuromonitoring changes and no neurologic changes during that distraction procedure. And you can see the change in her sacral flexion that occurred with basically much more verticalization of her sacrum occurring with the distraction procedure. Again, fortunately done safely just by going very slowly and again releasing her entire dural sac and nerve roots to allow them to migrate dorsally, which we saw during the distraction. So here's her final regional x-rays, her final long cassette photos. Here's her clinical wound photos, and she's 2 years post-op now, so we're writing her up to submit her as a case report. Is I think a very interesting case. So again, reasons being that this is a non-apical VCR level. You know, most of the time we do VCRs for 3-column osteotomies at the apex of the deformity. I didn't do that here, and I think that was the right call. So this is really a lumbosacral pelvic realignment case. Doing wide laminectomies, foraminotomies allowed dorsal dural and nerve root migration. I think was a good thing that prevented neurologic tension and potentially deficit on her. And again, very slow spine to pelvis distraction over several hours. So as soon as I got things exposed, the first thing I did was put temporary implants on her pelvis and her rib cage to slowly start the distraction procedure, because we had to do that over multiple hours to make this a 1-day surgery, because I didn't want to do a 2-day surgery, mainly because of a wound issue, right? To have the plastic surgeons close this twice would have been, I think, a nightmare. So we wanted to get this done all in 1 day if possible. And again, obviously, the use of plastic surgery, again, was essential for not only the tissue expanders, but ultimately wound closure and wound healing in the situation. So another kind of somewhat difficult and unique case that I found some challenging, but we were able to overcome that with the maneuvers we mentioned. Now, 2 adult cases. The first is a patient with neurophobatosis who presented with one of the most severe thoracic kyphoscoliosis deformities I've seen. So again, about 150 degrees in the coronal plane is best we can measure, and even more than 180 degrees in the sagittal plane. You'll see why. So his spine is bayoneted, and the spine basically is collapsing onto itself. So here's the 3D CT, which obviously shows the deformity much better. You see the severe angulation at the apex, the bayoneting portion of it, and the fact that, again, his proximal thoracic spine is actually falling more distal than his distal lumbar spine, so something we rarely see. Not surprisingly, he presented with very severe thoracic myelopathy. He could walk, but he had grade 3 to 4 strength in all his muscle groups. He had clonus and long track signs. So you see the thinning of his spinal cord there with what I call a type 3M spinal cord shape. So not only type 3 cord that's tented by the deformity, but also myelopathic. So to me, that's a type 3M. Only 2.5 centimeters of distance from the top of the bottom of T2 to the top of L2. So think about that. So he's basically got cor pulmonale, right? There's no room for his heart and lungs in this severely constricted chest cage from this severe deformity. So here's his clinical photos. You see what we obviously did on him to start. Not surprisingly, is halo gravity traction. So here's before we start traction on him. So I want to emphasize his pre-traction PFTs, FEV1 of 26% predicted, so 0.77 actual volume of FEV1. So if we take this patient right now to do a surgery, basically the chance of him needing prolonged ventilation, getting tracheostomy is nearly 100%, at least in my hands, in my experience. So we don't do that, obviously. We put him in halo gravity traction for 6 weeks, increases in height by 8.5 centimeters. We get his caudally angulated proximal thoracic region to now a cephalad angulated region, which is obviously beneficial for just exposure and also putting in proximal implants, getting his skull off his proximal spine. He gains 11 pounds in weight with nutritional work during the time he's in traction in the hospital. And you just see, he looks better. He looks healthier after this 6-week period of kind of preparation for his surgery, right before we dive into his reconstruction. Now his PFTs are 42% predicted FEV1 with a volume nearly 1 liter. And I get this patient now with a 42% predicted FEV1 through the surgery, possibly needing a few days on a ventilator and probably not needing tracheostomy. That's anyone over 35, 40% usually can get through a deformity surgery without a tracheostomy as long as we're very aggressive with post-extubation respiratory therapy. So again, here's his posterior wall and release picture of his what I call ribbon spinal cord over 3 or 4 levels, basically, before we do the posterior wall resection. Now here's his tubular dural pulsating spinal canal following the decompression posteriorly from his 3-level VCR. Here's his ultimate radiographic correction, again, following the 3-level VCR and correction, 3-dimensional correction from the deformity perspective. And here's his clinical photos. Again, neurologically normal by 1 week post-op, no complications. I only left the hospital 1 week post-op and did very well with this. So again, lessons learned in this case. Again, the benefit of halo gravity traction for adult deformities as well, along with pulmonary and nutritional improvement. Interestingly, we reported this in our paper that we published. He did have temporary complete loss of lower extremity motor function about 3 weeks in traction after sitting down on the toilet, actually. He kind of bumped probably hard, and we had to put him in the ICU and increase his MAPs and give him steroids, and he returned to normal about baseline function about 24 hours. But that's why I don't let someone with myelopathy leave the hospital in traction. I have them stay in the hospital. I don't trust them. So got to be really careful putting patients with myelopathy or a lot of spinal cord stretch in traction. You can do that safely, but you have to be very careful. Obviously, the benefit of pre-op conditioning to avoid post-op complications. It's extubated post-op early on and discharged to hospital post-op day 7, again, following pre-op. So, we pay the price either early or late on these patients. We decide to pay a bigger price early and get them healthier for surgery rather than kind of have complications afterwards and pay the price then. So, and again, a VCR for this kind of patient is ideal for both spinal cord decompression, for myelopathy, and for deformity correction. As we've learned treating these type of severe myelopathic patients. And the last case is vision, what I'm going to call grade 7 ischemic spinal optosis. And you'll see why I call it grade 7. So here's a patient in 1995, had this grade 4 high-grade ischemic spondy, treated with a posterior gill laminectomy and a posteriorly based fibular Bowman graft. I don't have x-rays post-op. Here's the pre-op x-rays. But basically, this patient presented to me now in 2021 with these photos, these x-rays. You see the long set x-rays, it's hard to see what's going on, but here's the regional x-rays. So what you can see here, and why I call this a grade 7 spinal optosis, is not only L5 below the top of the horizontal aspect of S1, but also grade L4 and L3 is. So obviously when L5 is below the S1 horizontal end plate, we call that a grade 5 spinal optosis. Now with both L4 and L3 below it, I'm calling it grade 7, something I've never seen before. So this patient presents with severe back pain, inability to stand upright for any length of time because of her trunk imbalance or her spine being so forward on her pelvis, and bilateral right grid and left grid and right leg pain, and grade 4 out of 5 anterior tibial AHLs, obviously from her neural traction of the L4 and L5 roots. So here's again an MRI showing her squished L5 roots, so somewhere down in that deep hole underneath the sacrum. And here's my CT scan. Here's my plan of resection from the back of obviously all of S1 and all of L5 to basically bind that her dural sac, bind her L5 roots, and then slowly flex the sacrum as well as kind of pull up on L4 and L3 and L2 to meet the realigned sacrum for her correction. Here we are intra-op, basically showing that you see the L4 screw, and kind of hard to see there, but deep in that hole is the L5 root that we found after a complete laminectomy. She already had a laminectomy of S1 and L5 from the previous gill, but we also laminectomized L4 and L3, again, to let the dorsal sac migrate, or excuse me, the dural sac migrate dorsally, and avoid impingement as we reduce this. And one thing I want to highlight here is that even though this is probably the shortest length operation that I'm showing you today, this is the only operation that I staged, mainly because I wanted to give the entire claudic equina time to recover from the correction. So we did about half the correction on stage 1, and a week later, the other half of the correction to allow the lengthening of the claudic equina and roots to tolerate that without any neurologic deficit. So just highlighting the benefit of two-stage surgery, which again, in my hands at least, for these complex problems, shows no increased complication rates than one-stage surgery, especially when we're doing complex VCRs. Surgery ultimate correction, you see we did an L1 to sacrum reconstruction. You see the 3 iliac fixation points on both sides. We couldn't get screws in S2. We tried, but there was not much left in S2. It was kind of worthless. We did put bilateral fibular grafts posteriorly from her lamina into her residual ilium for posterior healing, as well as some non-structural graft anteriorly. I couldn't dock a cage between L4 and the residual sacrum either. We see we have 17 centimeters of lengthening from L4 to the femoral heads in her posture. Here's her global posture, and she woke neurologically intact and has done so far well with this. She's around 7 months post-op now. So her lessons learned, again, understanding bony neural anatomy in a pre-op 3D model was very helpful prior to entering her spine and finding her L5 roots underneath the sacrum. And we did a full laminectomy of L3 to S2 with dorsal migration of fecal sac, again, with reduction, with kept things safe. We found and protect the L5 roots as soon as possible during the procedure. It was obviously a very high risk during this kind of procedure. We had slow, gradual two-stage correction and reduction to minimize neurologic traction injuries. Again, correction by sacral flexion, as well as L4 posterior translation with reduction screws to kind of meet halfway between flexing the sacrum and pulling the spine back posteriorly. So my quotas on these kind of cases, it's certainly better to be lucky than good. At the same time, you need to kind of know what you're doing and obviously prepare for these cases, because it is best to be lucky and good when you're doing these kind of complex deformities. So I thank you for your attention.
That was great, Larry. As always, those are amazing cases. And when we're trying to think of what talk to assign you, I said let's have Dr. Lenke talk about his most challenging cases. That was really impressive. How do you get models on every one of those? I saw that you showed, and I know we've kind of talked about that. Are you still doing that?
Absolutely, yeah. Honestly, that's my kind of 3D prep navigation is from a bony perspective, obviously, is to get a 3D model. So all those 4 cases had models made, and I don't make models for every case. Probably right now in my practice, a third to half of my cases get models. Anything with congenital deformities, obviously there's aberrant anatomy, anything getting resection procedure, we'll get a model made as well. And And again, I have a very low trigger. So I do also, my fellows love it. The fellows love, because they get to obviously to handle and study the model pre-op as well. So I do it as much for fellow and resident education as I do for my own education. As you know, those models are in a clear sterile bag. I don't use navigation or fluoroscopy. All my implants are placed freehand still, even on these type of deformities. But again, I certainly use that model to prep for my screw placement and deformity resection and correction. And then also, again, the model's in the OR with me. So if I can refer to it real time. That's my intra navigation and imaging.
And then how about as far as neuromonitoring, in the couple cases that you showed, because you're in the lumbar spine, obviously motors aren't as effective. So what do you what do you do in terms of like trying to figure out, hey, did I correct this too much or?
Sure. Yeah. Motors actually aren't perfect, but they're pretty good. We're finding even for lumbar nerve root issues as you do more, as the technicians also, we got a stable crew of technicians at Columbia now for 7 years. As they've done thousands of cases with us now between myself and my partners, they're getting really good at picking up even stretch neuropraxias. It's not perfect, as you know, Rod, but they're getting better, just like we're getting better. I don't hesitate to do direct nerve stimulation pre and post. Lengthening of lumbar roots, that'll pick up root traction injuries, which is, compression injuries, compression issues will be picked up by monitoring pretty quickly and relieved by more decompression. But it's the stretch neuropraxias that get us, because often monitoring won't pick up stretch neuropraxias. The string test, using a Penfield for something and seeing how tight a nerve root becomes as you're putting correction maneuvers on the lumbar spine is helpful, but that's not objective, that's subjective, right? But certainly direct nerve root stimulation and increasing intensities of stimulation to produce a muscle response in the corresponding muscle of that nerve root is very helpful. It's not perfect. Again, nothing's perfect, but I use all those modalities, including even doing a wake-up test, Rod, if I need. I'll do wake-up tests. Like on that high-grade spondy, I should show. I did wake-up tests on her after I corrected her to make sure that she didn't have a dorsiflexion weakness, which would be the most common thing to see. Because I've been fooled in that, even though the monitoring stays stable. So I'll use everything, including wake-up tests, to make these as neurologically safe as possible.
Hey, Larry, thank you. This is Jens for taking on these really this vague assignment with such fervor, and every one of the cases deserves in-depth discussions, but time won't permit us to do that. 2 quick questions. Spondy case, high-grade spondy case. I still suffer from L5 symptoms occasionally, despite being very careful and avoiding any over-distraction, over-reduction, etc., but realignment. Daniel Chopin emphasized after these high-grade spondy reductions to position these patients for about 48 hours with their hips flexed and knees flexed to take the tension off the sciatic nerve. Is there any conceptual merit to that? And then when they're fully awake, progressively stretching it out?
Right. Absolutely. I know for a fact I've had patients that wake up normal. I do a wake-up test. No one leaves my OR before they got a wake-up test. And they wake up normal dorsiflexion. The next day I see them on rounds. It's 6:30 a.m. and they're 2 out of 5 and 1 or both feet because they've sat basically straight all night long. So, but what I do, you think about it, the relaxed position for the sciatic nerve is with hip extension and knee flexion. So that's how I position my patient post-op, on their side, but I extend their hips and I flex their knees. And the first thing I do is start straightening their knees out as they tolerate it. And sometimes they're so tight actually that they get pain doing that. So you stop. And I've had to keep some patients with high-grade spondies on their side for 2-3 days with steroids and slowly extending their flexed knees while keeping their hips extended to relax their L5-S1 roots until we can get them straighter. And then basically, once they're more comfortable, it usually takes a few days, you can get them up and going. So I absolutely do feel that post-op positioning for these patients is really critical to avoid, again, it's stretch neuropraxias, right? And positioning post-op is very important. But if you think about it, the best way to position them is with hip extension and knee flexion. It's the femoral stretch test, right? The femoral stretch test relaxes the sciatic nerve, right? But so because hip flexion actually increases the length the nerve has to run. So you actually want to extend their hips and flex their knees.
Great point. The second brief thing, and then we'll have to move on to the lab where Chris has prepared a cadaver. We'd love to have your insights there also, is neuromuscular deformities. So we obviously always want to fuse the least amount of vertebra. And that first case that you showed was very evocative for me. Because again, in the bigger picture, neuromuscular seems to be particularly prone to decompensation wherever we stop. As a general rule, is the Gestalt rule correct that for neuromuscular, think bigger rather than smaller, as long as it's safe for the patient?
Yeah, unfortunately, the problem is neuromuscular is their whole body's affected, right? And it's not just their spine. So if you stop short on those kids or adults, they're going to decompensate. Their tissues are just poor, right, through their entire, total body neuromuscular condition, whatever it is. So it's hard to stop short in these patients. There was a trend to even stop at L4 and L5 and Duchenne's and other neuromusculars, and that trend is passed because those patients didn't do well. And then they get these very rigid, severe lumbosacropelvic deformities that are very difficult to treat. It's much easier to just take care of that in the very beginning. And honestly, as we know from adults, patients do fine, if they have to have their spine fixed to the pelvis. It's not ideal, obviously, but they can play tennis, they can play golf, they can ski. I've got tons of adults fixed, the sacrum pelvis that do a lot of activity. So it's not a death sentence, in other words, if you have to have your spine fixed to your pelvis. But as long as it's in a good anatomic position, right? You have a good alignment, as you guys have talked about today. So.
Great stuff. Stay online for a second. Let's check in the lab and see if Dr. Shaffrey is ready. He wanted to show some tips and tricks for